than one word for some of these. So it can be cranial or superior, or it can be caudal or inferior. You can have ventral or anterior, posterior or dorsal, and then we have palmar and molar, and then plantar. Got it. And y'all have a huge list of these in your handout. I would know these. They're going to come up forever. They're going to come up in all of your dissections, and you'll have at least one question to ask you something about medial or lateral too. Like I said before, it'll probably be the thumb or the fingers because that's the part that most people kind of get confused about. Same with these. The one that they really like is circumduction, which basically is doing something like this, so that it looks like a cone. I think that's what our question was. And I'm pretty sure you'll also have a CT question, and it'll just, they want you to know that it's taken from the feet up. So when you're looking at this, what's on your right side is actually their left. And the top part is up, and the bottom part is down towards the spine. And as if they're lying down, like you're looking from their feet towards their head. Alright, muscle groups. We also had a question on this. So you'll have their superficial, intermediate, and deep. And basically you can know which muscle groups go into which of these, and then what they're innervated by. And the way that we remember this is that the deep is innervated by the dorsal roots, right? The dorsal primary lemma. So they both start with D, and the other two are innervated by the ventral primary lemma. Except for the trapezius. That one's kind of low lemma. These most likely won't be on your lecture exam. Most likely what you'll see is they'll lay one of these on top of one of the tanks, and they'll ask you to identify it in the actual practical. So cervical, they're the really small ones. The key to identifying these is actually that they have these types of them. If you see that, it's cervical, and also this part's kind of small. So for the thoracic, to me, this one didn't really have a huge defining feature. They tell you to look for the costal facet, so look for the little indentions. The lumbar is the really big one. This part is going to be huge, and it's going to be really thick. And then sacrum, you guys know what that looks like. It's fused in the top. Curvatures. So you have primary and secondary curvatures. And they'll probably ask you, if they do ask you about this, they'll ask you what persists. So you can see like the primary curvature over here, you can see that it persists in certain areas. And they might ask you, so the cervical region, you're going to get that at about 3 to 5 months from the baby starts to pull their head up. And the lumbar region at 9 to 13 months from the baby starts to pull. So that's the only thing they ask. So they really care that you know that the subarachnoid space is where the CSF is located. Okay, first question. Does anyone know these? For the baby or what? And the adult? Who said L3? I heard it. So it came back there. Alright. So know that. Most likely they will ask you, they'll give you like the spinal cord ends off and ask you the age of the patient. So if it ends at L3, it's a newborn infant. If it ends at L1, L2, it's an adult. Anywhere in between is a baby or a child, and that's how you'll figure out what the age of the patient is. Is that in your notes? That wasn't in our notes. We just did it by today. Okay. couple other landmarks for like 6 months of age or a year of age. But on the test, they won't give you one of those landmarks. Like they won't say that the spinal cord is at L1, between L1 and L2. They'll say it's at like, I don't know, L4 or something. And then they'll ask you the age. And it'll be in between one of the landmarks that they gave you. So you just have to pick the age from the answer choices that's in between those two age ranges. Does that make sense? There's a lot of Galen questions like that. Alright, lumbar puncture. You will have a question about this. It will ask you either what's next, what came before, or the parallel order as well. I don't have a good way to remember this, you guys. You just basically, if you know the anatomy, if you can picture it, that's the easiest way for me to remember it. So you'll see it goes through from here in skin into a supraspinous interspinous. Ligaments and flavor, they will ask you where you're going to hear a pop. That's at the ligaments and flavor. And then you're going to keep advancing the needle just a little bit through the dura and the arachnoid into the subarachnoid space to try and get that. Make sure you guys know where the pop happens. That was a question on our test.
And know that you do not pierce the pia.
Yeah, you never pierce the pia. Don't do that. Alright. First question. I guess real question.
What's that?
Okay. A 55-year-old man is admitted to the hospital after an injury sustained at work in a factory. He presents with severe scalp lacerations which were sutured. After 3 days, the wound is inflamed, swollen, and painful. Between which tissue layers is the infection most likely located? Eight. Yay. Alright. Similar question. A 55-year-old man is admitted to the emergency department after slipping on wet pavement and falling. Physical exam reveals that the patient has a hematoma that formed in the danger zone of the scalp. Which of the following areas is regarded as the danger zone? Perfect. You got it. Alright, so y'all know this. Most likely you'll get a question either which one is the danger space, what is it located in between, things like that. And they might also ask you why it's considered the danger space. Do y'all know why? And the movable parts, they got them. So, why is this yeah, so there's this area, there's nothing much in there, and if the infection gets into it, it can spread all the way throughout the scalp. Okay. Also, the movable parts, that was, I think, a question I had in one of our quizzes for the exam. The first 3 layers of the scalp are the movable parts. Okay, so we've already kind of talked about this, the dura, arachnoid, and pia. You want to know the order. You want to know that the pia is going to be adhered, and so you'll be able to see the grooves in the brain, even if the pia is still on, as opposed to the other ones. And you want to know that the subarachnoid is where the CSF is. Have y'all talked about how it's different in the brain and the spinal cord? Okay. So you also probably want to know that. We didn't have any questions on it, but I guess I could ask you. These you're going to want to know, and you want to know what their attachments are. The only thing that they care about you knowing is the falx cerebri, the tentorium cerebelli, and the falx cerebelli. The only ones that you need to know attachments for are the first 2. So the falx cerebri attaches the vestibular, so it's right here. And it separates the hemispheres. And then the tentorium is this one that kind of like forms a tent in the back. And that attaches to the occipital bone at the petrous ridge. That would be the petrous ridges. And the free edge is attached to the anterior clinoid process. So the answer choices, or the correct answer will either be the petrous ridge or the anterior clinoid process if they ask you where those attach. Alright, circle of Willis question. They love the circle of Willis. It was in our practical, it was in our exam, probably more than once in our exam. They really love this. And it's also in our neuro exam now, so just remember it. The arterial circle of Willis contributes greatly to the cerebral arterial circulation, and one primary artery becomes occluded by the PCs. Which of the following vessels does not contribute to the circle? A 54-year-old woman is admitted to the emergency department after experiencing sudden problems with her vision for the preceding 5 days. Radiographic examination reveals that an aneurysm of one of the arteries at the base of the brain is compressing the optic chiasm. Which of the following arteries will most likely be involved? Somebody said B. Does that make sense to y'all? So y'all dissected the circle noise yet in lab? Yes? Okay. So when you do the dissection and you see it comes up, so the vertebral arteries come up and form the basilar, and then it splits right, and the individual goes through, goes forward. And then the anterior communicating is this one right at the front. And so that's the one that's going to be closest to the optic nerve up here, right? And that's why it's going to be vision problems. Does that make sense?
Everybody knows what aneurysm is, right? The bulging of the.
Yeah.
Can you go back to the first question?
Sure. This one?
Yeah, why is it that
The internal carotid. So the internal carotid is actually what leads into the anterior part of the circle. So the internal carotid is going to split and give off your anterior and your middle cerebral. So I don't know if this is right. So here's your internal carotid. That's your internal carotid, and that's going to be your way to your middle and your anterior. Probably more than you guys need to know, but this is considered the anterior part, and then this is considered your posterior circulation. So the vertebral artery, the basilar, is the posterior, and that gives off your posterior communicating. The internal carotid giving off the middle and the anterior is considered the anterior circulation. So the internal carotid is in there just because it splits off.
And it's more posterior from where the optic chiasm is going to be more lateral. So within the brain, so it's not even close enough to cause an injury.
Yeah, so the only one that's not part of this actual circle, like the middle cerebral is not going to provide collateral blood flow for anything, right? That's what this picture is basically showing you. Alright, next question. A 40-year-old unconscious man is admitted to the emergency department after being hit in the head with a baseball. A CT scan examination reveals a fractured perion and epidural hematoma. Branches of which of the following arteries are most likely to be injured? Yes. Middle and middle. Do y'all have any questions about that?
So if there's a question about an epidural hematoma, it's most likely going to be the middle meningeal vessel because of how an epidural hematoma occurs. You all are familiar with the mechanism of how that happens? Okay. So what happens is that you know how y'all talk about the inner table and the outer table of the skull? Okay, so you have your inner table that lines the inside of the skull, and then right interposed within the interdigitation of the middle meningeal vessels where they run at the skull, you have the vessels right there, and then right underneath that, the next layer is dura. So the first layer of dura is the periosteal dura, right? So when the vessel gets hit and it starts to rupture, it fills the space between the inner table and the periosteal dura. It actually starts dissecting the dura away from the inside of the skull. And so that's even why it takes time for an epidural hematoma to present with symptoms, because you have to actually dissect away from the skull before you start impinging on the parenchyma of the brain. Does that make sense?
And the most likely way that they're going to present this to you is a guy getting hit in the head with a baseball or with something else, a club, they get a fight. Some way this guy's going to get hit in the side of the head. He's going to have that. Alright, a 65-year-old male is admitted to the hospital for 2 weeks after a small bump on his head was breaks with his. He suffered an accidental bump from a low-hanging branch while driving his tractor through the apple orchard. During a physical exam, the patient displays mental confusion and poor physical coordination. Examination reveals leakage from the cerebral vein over the right cerebral hemisphere. From what type of bleed is the patient most likely suffering? Okay, so this is from your notes. want you to know. So epidural space is always, in your test, it's always going to be metameningeal. Subdural space is going to be the superior cerebral veins, and then the subarachnoid space is going to be a cerebral aneurysm. Know these, it'll be one of these 3 questions on the test. Alright. The arachnoid villi allows cerebrospinal fluid to pass between which is a tube called. So we're going to talk about the CSF circulation. This will also be a question. So there's really, we're just going to memorize it. It goes, CSF is made in the choroid plexus, which is located in the lateral and third ventricle. So it's going to go from the lateral ventricle through the frontal row to the third, through the cerebral aqueduct to the fourth. And it keeps going. The arachnoid granulations are what's going to take it back up and then dump it into your sinuses. This will also be a question for hydrocephalus. They will tell you one of these is blocked, but they won't tell you which one. They'll just tell you what's dilated. And so if they tell you that your lateral and third ventricle are dilated, but everything else is normal, you're going to know that it's the cerebral aqueduct that is the site of the blockage, right?
What is this cerebral aqueduct? What else are we doing?
Do you have like a
There's a picture.
Yeah.
okay.
So the big, all
What is happening?
and all these concerns are just windings of the subarachnoid space. And there's, because there's spaces within the brain that aren't always accumulated by tissue, like the other things that had.
There's something that you have ever
Was there a couple questions?
she said it's her name.
Any other questions? A 17-year-old woman is admitted to the hospital with signs of cavernous sinus thrombosis, as revealed by a radiographic examination. Thrombophlebitis in the danger area of the face is spread to the cavernous sinus and involve the ophthalmic branch of the trigeminal nerve. Which of the following symptoms will most likely be present during physical exam? So this is your cavernous sinus, right? They're going to ask you in some way something about cavernous sinus thrombosis. Either what are the nerves involved, what are the symptoms. Something about cavernous sinus will be a question on your exam. And then these are the cavernous sinus thrombosis symptoms. Most likely they will be a patient that has these symptoms and ask what they have, how they got it, or something like that. A 35-year-old woman is hospitalized due to cavernous sinus thrombosis resulting from an infection on the face. Which of the following is the most direct route for spread of the infection from the face to the cavernous sinus? Yep. Very bad. Early closure of the fontanelles of the infant skull can result in compression of the brain, restricting brain growth. Which of the following fontanelles is located at the junction of the sagittal and coronal sutures, and at what age does this fontanelle typically close? This was pretty much exactly a question. Yep. Good job. Okay, good. Posterior is anterior. So y'all need to know they will ask this of you in some way. Either the baby, they might tell you that the baby still has a soft spot up here, what age are they? Or a soft spot back here, what age are they? Or they might give you like the suture and ask what the spot is called and what age it closes at. But in some way they'll ask this. Okay. Early closure of the fontanelles of the infant skull can result in compression of the brain. Wow, that's sick. Okay. Which of the following fontanelles is located in the junction? Wait, that is the same. They just call it something else. Alright.
And nothing. babies that's supposed to 16 months.
Took this.
Y'all have any questions?
Yes.
About?
That's a nice way to call it today. Oh, wow.
There's just different names. Posterior and anterior, right? So anterior is 2-year-old, up to 2-year-old, is soft. Posterior is only up to 2 months. So posterior one is not soft. So they could also just
Masturbate this is This is in place.
Okay, so I'm responsible for covering y'all's intro to the nervous system, the spinal nerves, embryos, the CNS, and the autonomic nervous system. So just going to start off with some generalizations, some big points, some big picture things that you guys need to know for your exam. So talking about the differences between the afferents, the efferents, and the preganglionic efferents. So afferents are anything that is sensory. So this is stuff coming in from the body wall, this is stuff coming in from the viscera. And any afferent is going to be in sensory ganglia. Because like we're going to talk here in a little bit, all sensory things and all ganglia are going to be derived from the neural crest. And so this is basically the domain of afferent and sensory ganglia. So efferents to skeletal, if they're talking about fibers, where are these fibers coming from? It's going to be the ventral horns. Now the preganglionic efferents, you have your two different systems. You have your sympathetic and then you have your parasympathetic. And don't try and distinguish the differences of these two systems based off of function because it really gets too convoluted. Some of the things we're not even quite certain depending on the anatomical region. But know anatomically what their differences are because sympathetics are always thoracolumbar and sympathetics are always going to body wall. You're never going to find parasympathetic fibers in the body wall at all. But sympathetics, along with the body wall, are going everywhere else because these are also following along blood vessels. This is what gives you your tone in your arteries and other things. So this is always going to be thoracolumbar no matter what. And the cell bodies are always going to be in the intermedial outer cell column. And is everybody clear on the concept of a cell body and what that means? So the cell body is basically the nucleus of the neuron, and it's where it's housed before it branches off into its efferent branch. Parasympathetics, on the other hand, are more discretely organized. It's either in the head or in the sacral region. So it's therefore called craniosacral. So if you get a question asking where is the cell body of a parasympathetic neuron, it's always only ever going to be in the craniosacral region. It's not going to be anywhere in the spine or something like that. It's going to be in the cranial nerve nuclei that have parasympathetic function, so they're listed right there. Or the sacral autonomic nucleus that's listed right there. So S2, S3, and S4. And you'll learn a little bit why the sacrum has to kind of like have this. Is that clear so far? Cell bodies, differentiations. Okay. And then talking about sensory ganglia, the ventral horn, things like that. So we know that the sensory ganglia are associated with afferent fibers. And we know that afferent fibers are associated with the dorsal horn. Well, these afferent fibers in their cell bodies live outside of the CNS. They're not considered CNS products because also, like we're going to talk about, they're derived from neural crest. Neural crest gives rise to everything in the periphery. And so it makes sense that their cell bodies have to be occupying in a ganglion because it's not in the CNS, otherwise it would be called a nuclei. And it's going to be the dorsal root ganglion. So sensory is always dorsal horn. Always has to exit out of the dorsal horn, or I guess technically it's coming from the dorsal root ganglion. Its central axon is going into the CNS. And then its peripheral axon is coming out from the periphery, and that's what's giving you your sensation from your limbs, from your trunk, and things like that. And then, because these are the pseudo-unipolar neurons that you guys know about, does everybody remember what those are, what they do? So basically you have your cell body that's in the center, and then you have the two axons that go out. So if my head's the cell body, and this arm is going to the CNS, it's the central axon, if this arm is coming out from some sensational area of my limb or the trunk, it's my peripheral axon. It's from the periphery, hits the cell body that's in the dorsal root ganglion, and it goes in through the dorsal root into the CNS. Is that clear? Makes sense. Other things that we can look at while we're here is the ventral horn that we're going to get to. And like I said, if it's ventral horn, then you know it's efferent. Efferent everything on top of sympathetics, because sympathetics are housed in the lateral horns that aren't quite labeled, but it's, oh yeah, it is. It's this little hump right here. That's where the intermedial lateral cell column is carrying your sympathetics from T1 to L2. And that's also an important concept that's always asked, is where is the intermedial lateral cell column? It's T1 to L2. Know that for the rest of your life. So ventral horns, and then we'll talk about a little bit about their course here. So, where do I have another slide? Okay, yeah. So, anything coming out, so we've talked about the dorsal rootlets, which are carrying the efferent fibers, and then here's your dorsal ramus and your ventral here that meet for a very short distance on the spinal nerve. And then from there, they branch off into your dorsal ramus that goes to the back, and Kat was telling you about the muscles and things that get innervated by dorsal rami, and then also branches forward to get your trunk musculature. So this is on the ventral primary rami as well. So you need to know the concept of dorsal horn, ventral horn, dorsal rootlets coming down, ventral rootlets coming here, and then the spinal nerve. And I think a lot of people kind of get confused about the spinal nerve and what it does, because it is a very short distance. But if you think about the fibers that are coming into it, because Dr. Johnson loves to talk about fiber composition in her nerves, the spinal nerve is carrying everything. Because you have the afferent fibers that are coming in, meeting the spinal nerve. You have your sympathetics and your efferent musculature that are coming out of the ventral horn, that come down and merge with the dorsal root, okay, right here. And that's your spinal nerve. So I know in one of her anatomy and action reviews, she pulls up a paper that has a sketched spinal cord, and it shows that it has rootlets and things like that. And she went through with y'all to draw the fibers, and she did it in different colors and labeled all of that. Did everybody kind of like go to that review? That's a really high yield review. And a very good image to kind of have stuck in your head as far as like the fiber composition of each of these parts of the spinal nerves, and then where they meet, and then where they branch off as well. Because that's going to be valuable material. Is everybody clear on those compositions, kind of the organization of the fibers as they're coming out of the cord? Or is there anything that's unclear about it? Okay. So the intermedial lateral cell column, just to reiterate, goes from where? What's that? What'd you say? Okay. So that's the intermedial lateral cell column. What fibers, what cell bodies are living there? What's that? Huh? Sympathetics. Okay, great. So, and then where are sympathetics going? Everywhere, right? They go everywhere. Where are parasympathetics going? And sacral region, right? So, just showing this, talking about the course of sympathetic fibers. Okay, so she went over with you guys like the three different options of the preganglionic fibers, and then the postganglionic fibers and all of that. So, with your first option, you go from what horn? Okay. And then you go through your ventral rootlets, then you go through the ventral root, and then this right here, the more medial branch connection to the sympathetic trunk to the ventral ramus is what? Gray. Okay, so gray, I always think gray going out, because that's where the fiber's going to go out. And then white comes within the sympathetic trunk. So white within, gray go out. So it's going to pass the gray ramus, and then it's going to go into the white ramus into the sympathetic trunk. So I'm still preganglionic fiber. My cell body's living in what? Right, because I haven't made a synapse with anything. And then now I have a couple of decisions that I can make. I can either synapse right there in the trunk that I just entered at that spinal amount of time to innervate or synapse at some other point in the sympathetic trunk. Now, that's one option for the preganglionic fiber. Now, if I'm wanting to get to thoracic viscera above the level of T5, then what I'm going to do is get into, I know it says splanchnic nerve here, I can never say that word, but just imagine that we're above the level of T5, okay? So what thoracic viscera, how they get innervated is that this preganglionic fiber, and it's still preganglionic, so its cell body is living where? Intermedial outer cell column. It's going to follow the same course. So ventral rootlets, spinal nerve, ventral ramus, in through the white without synapsing in the sympathetic trunk. And it's going to go out directly through a visceral nerve. And visceral nerves are specific for thoracic viscera above the level of T5. Because we're going to talk about, once we get to T5 and below, are what? Does anybody remember? It's on this splanchnic nerves, right? And so those have a different organization that we'll talk about. So, I'm still preganglionic fiber, I have not synapsed here, and I'm going to go all the way through my visceral nerve into a specific collateral ganglion, which is going to be basically embedded in the wall of whatever organ that you're innervating, typically the heart. And then synapse in the collateral ganglion. And then that's where my preganglionic fiber actually innervates and causes the action directly in my effector organ. And I'll talk about effector organs and things like that. So, one more option for preganglionic fiber is a little bit of a weird one that some people may not remember. But I come out, my cell body is still in the intermedial lateral cell column, follow the same route that I've been doing, going through the white, and then go down to some level below T5, and then pick up with the splanchnic nerves here. Okay, and this is actually what this is showing us, this third option. Do something. No, I know what to do. So, I'm still preganglionic. I'm the first neuron in the chain, and then I go to the adrenal medulla. And then the adrenal medulla has chromaffin cells and other neuroendocrine cells that we're going to talk about that are neuropress derivatives. And so they are technically specialized cells that are your second neuron nerves. So they're basically your, what am I wanting to say? Your postganglionic nerve. Okay, so to reiterate, I have a preganglionic fiber going to the adrenal medulla, and that means I'm going to cross through the ventral horn, or the ventral rootlets here, get into the ventral ramus, go in through the white, go down to some thoracic, or to some splanchnic nerves so below T5, and then carry through that nerve without synapsing, and synapse directly onto the cells of the adrenal medulla that are your neuroendocrine cells, that are your neuropress derivatives, and are your postganglionic fiber, technically. Although it's not a nerve fiber, it's a cell, it is homologous to a second order, a postganglionic fiber. So is everybody kind of clear on the options that we have with synthetic scissor?
So it's labeled the splanchnic nerve for below T5?
Yes.
Above T5, what's it called?
Above T5 is visceral nerves. Yeah, so that reminds me that I actually didn't cover the next part of that. So if I'm going into a splanchnic nerve, then I guess it's still the same thing as the visceral, but it's called a different name. I'm going to synapse on the collateral ganglion, and these are your prevertebral ganglions. So prevertebral means that I'm in front of the body of the vertebral body. If I'm paravertebral, which is all of the sympathetic trunk ganglion, that's paravertebral because para means alongside of the vertebral bodies. Have y'all dissected out and seen where the sympathetic trunk is actually along the vertebral bodies like that? Once you get to abdominal, thoracic, and pelvic, you'll start seeing these named prevertebral ganglions, so like the celiac ganglion, the superior mesenteric ganglion, things like that. So it'll make more sense and not be so abstract once we actually get to that point. But yeah, your splanchnic nerves are still carrying your preganglionic fibers. They haven't synapsed because they're going to these prevertebral collateral ganglion where the synapse is going to occur. And then from there, your postganglionic fiber is going to carry out and innervate the viscera. you have a question?
Hey, where's the cell body for the visceral nerves?
The visceral nerves, so we talked about how they come out of the IMLC is the cell body of the preganglionic, and then there's actually a synapse that occurs here in the sympathetic trunk. So for visceral nerves are technically carrying postganglionic fibers. Does that make sense? So because the synapse has to occur here in the sympathetic trunk at some level before the visceral nerves are allowed to come out as postganglionic fibers. So that is kind of an acute distinction to make. So if you're T5 and above and you're a visceral nerve, you're carrying postganglionic fibers. If you're T5 and below and you're splanchnic, you're still carrying preganglionics, but they're going to collateral or prevertebral ganglion. Is that clear?
Do you know the upper cutoff for the visceral nerves?
Well, the visceral nerves, once you get above T1, then you're becoming cervical. So, and we'll talk about that here in another slide. So those are superior cervical ganglion. And that's a different organization. Yes, sir.
All right, so the visceral nerves carry postsynaptic fibers. So the synaptic nerves will be paravertebral
Ganglion.
and they also contain fibers that will synapse in the prevertebral ganglion.
Yes. Or are you talking? I'm sorry. Reorganize your question. Are you talking about visceral nerves?
Talk about
Visceral nerves are the postganglionic fiber. So they synapse directly onto the effector organ. So there's no collateral ganglia above T5 that's operating this system or that's working in conjunction with these fibers. The collateral ganglia are the prevertebral ganglia that are in conjunction with the splanchnic system. Okay, because the splanchnics are carrying your pre-ganglionic sympathetic fibers still. There hasn't been no synapse occurring in the sympathetic trunk. So to follow the course of preganglionic splanchnic nerve, let's talk about that. So you're in the ILCC, you have your cell body there, so you're a preganglionic sympathetic fiber. You come through the ventral rootlets, and then you're coming through the spinal nerve, the ventral ramus, and shooting into the white ramus communicans. If you're going to a splanchnic nerve, you have not made a synapse here. Okay? You carry on, the T5 and below, you carry on through a splanchnic nerve, okay, to a prevertebral ganglion. Ignore this setup. This is all for the adrenal medulla, so it's not going to show it the same way. But just look at the yellow portions. Okay? And I'm still splanchnic. That's not going to the adrenal medulla, and so I actually synapse on the postganglionic in a prevertebral / collateral ganglion. And then from there, I'm innervating directly my effector organ. Does that clear that out? Yes?
I think so. Just reiterating, make sure.
Okay.
So you pass through ventral, go to the white ganglion, pass through the paravertebral ganglion, go to the prevertebral body, and
Prevertebral ganglion. And then the synapse has occurred in the prevertebral ganglion. And so from that point on, you're a postganglionic nerve fiber. Okay? Yes, ma'am.
Just two questions. The first one is, if you're going to the splanchnic, it never crosses the grade.
No, it has no purpose to. If you're going through the gray, that means you're supplying sympathetics to the body wall. So you're a postganglionic fiber at that point. Because if you're going out of the sympathetic trunk, that means a synapse had to occur before you could come out of that.
And just to reiterate, you said for viscera, so viscera is above T.
Visceral nerves are T5.
So, and they also do the whole, like, it's the same thing that the nerves that go to the body wall.
Right.
They synapse at the paravertebral ganglion, the sympathetic trunk, and they go directly toward the
Right, that's postganglionic fibers.
Right, and then the body wall will go directly to the body, so that's.
Right, and if they're going to body wall, to the back or to the trunk, then they have to go out of the gray to pick up the dorsal primary ramus if they're going to the back, and the ventral primary ramus if they're going to the front.
They say that above T5, all the snaps are happening in the synthetic trunk, or.
Yes. Yes. So then thank you for making that a point, because that is a crucial point. Yes, sir.
So there will be no prevertebral ganglion above T5.
Prevertebral ganglion above T5? Yes, there will be none of those. Because all the prevertebrals correspond with T5 and below. because those are splanchnics, and splanchnics are still carrying the preganglionic fibers. And then once you've picked up the collateral ganglion, carried on from there, then you're a postganglionic fiber. Yeah, so there are concentrations. So you'll see once you get to the sections of the abdominal viscera, the celiac ganglion and the pituitary ganglion sitting on top of the aorta. So that's kind of where they concentrate. What's that? Yeah, I know, but he was asking, so I was just clarifying. Does that kind of clear up the course of the sympathetic fibers? I know it's convoluted and you have to keep track of what region of the body it's innervating, and then the pre- and postganglionic fibers, but do take the time to learn these distinctions. Now, was there another question? Okay. Ask away. I don't know if there's a hand. If you have a question, just shout it out. No? Okay. Another distinction about the splanchnics is that they're not just carrying sympathetic fibers, and this is something I think kind of gets overlooked at times. Because you have afferent fibers, so your afferent fibers are their cell bodies are living where? Where? Okay. Dorsal root what? Right. Because are they inside or outside the CNS? Okay. So your afferent fibers coming from your viscera have to get back to the CNS somehow. And so they actually use the splanchnic fibers, or the splanchnic nerves, as highway routes to get back in. Okay, so from a reverse route, if they're coming from the abdominal region, the afferent peripheral axon that we talked about is going to carry on through the splanchnic nerve, through here, and actually through the white, and then it has its cell body here in the dorsal root ganglion, and then enter the dorsal form with its central axon. Does everybody remember that being taught? Ish. Okay, and that kind of like brings up the whole concept of referred pain and things like that, because the fibers kind of get crossed, and the brain has a difficult time distinguishing at times where the pain and afferent sensory is coming from. Is there any question on this before we move on to the next slide? Okay, so this is basically a reiteration of what we've been talking about. So sympathetics, again, this is thoracolumbar, and the IMLCC goes from where to where? Where? I can't hear everybody. Okay, there we go. Okay, so, and then we talked about the paravertebral ganglia. So the sympathetic trunk is where these cell bodies are going to be for certain fibers. We talked about the collateral and prevertebral ganglia via the thoracic and the lumbar splanchnics. So again, the splanchnics are always going to be associated with the collateral ganglia because they need somewhere to go to pick up that second fiber in the chain. And then your adrenal medulla, we talked about how that's neuroplastic anomaly, and some of those cells are neuroendocrine. And so those cells of the adrenal medulla actually act as your postganglionic fibers and get direct synapse from your preganglionic fibers. Okay, and also using the splanchnics as routes to get down to the adrenal medulla. And then parasympathetics are your craniosacral. So, I mean, these just kind of have to be memorized as far as which cranial nerves are carrying parasympathetic innervation and what ganglia are associated with them. Okay. And then the sacroautonomic plexus, yes, it's sacral, and yes, it's parasympathetic because craniosacral. So, always remember those big picture generalizations because I think sometimes we get bogged down in details, and so it's difficult to kind of broaden our perspective and just remember the basics. And then these are called terminal ganglia because they're synapsing on their second neuron that are basically embedded in the wall of, like, for the bladder, for instance, and things like that. So any questions on that? Okay. And so we've already kind of been talking about this. I say not so elusive fibers of the spinal nerves because if you think of what's associated with each of these portions, you'll know what fibers are in them. Okay? So for your dorsal root, always, always, always afferent fibers coming from the dorsal root ganglia. Why? Because these are pseudo-unipolar afferent fibers that have to have their cell body living outside of the CNS because they're neural-crest derivatives. Okay. Ventral root, only two things come out of the ventral horn, so the ventral root is always going to carry your preganglionic sympathetics from the IMLCC, and then your efferents to skeletal. Okay. And then your spinal nerve, like I was telling y'all before, is a fusion of your dorsal and ventral roots, and so it would come to reason that that fusion point is going to carry all of the fibers that are in these roots. Okay. Does that make sense? So I want you guys to remember these big picture things because this is what's going to be tested on your exam. You know, so this is pretty high yield information. And Dr. Johnson loves asking questions about fiber types, fiber composition. The ventral ramus, we've already been talking about. So the ventral primary ramus literally is carrying everything, including preganglionic sympathetics. And then the wide ramus communicans. So these are the input regions from the preganglionic fibers. So these are only at T1L2 because the IMLCC is only at T1L2. But the gray ramus communicans is at all spinal levels because if you're not T1L2, you still have to get sympathetics. Why? Because we know that sympathetics go everywhere. So they still have to have exit points from the sympathetic trunk to hitch the ride on whatever nerve fibers that they need to innervate things of the face or of the pelvic region. Okay? And so gray ramus communicans, if you're coming out of a gray, going out gray, then you are postganglionic sympathetic only because your synapse occurred somewhere in the sympathetic trunk. Okay? Does that make sense? Yes, sir.
In the great, I feel like we're talking about this, but in the gray ramus communicans, I think we just talked about it, how you said the afferent coming back to the CNS, it passes through it, is that correct?
Passes through the white.
To the white? Okay.
Yes.
Thank you.
So muscle, skin, and joints. So the way that I made these PowerPoints was I looked at y'all's learning objectives and I tried to take the big learning objectives and basically put material from this. So this is all coming directly from muscle learning objectives essentially. So muscles, well it's skeletal, so if you're going to muscle you have to have efferents to skeletal. And then you have to feel stuff in your limbs and in your muscles, so you have to make sense that if you're going to muscle, you're carrying afferent fibers with you. At the same time, you have sympathetics everywhere, and sympathetics follow along blood vessels as we've talked about. So you have postganglionic efferents that are here. So if you think about, you know, what is this portion that's just talking to me about muscle, skin, and joints, then you can kind of reason out, rather than having to memorize things, you can reason out what needs to be there. Okay, does that make sense? And skin and joints is a similar story. So skin and joints, well, you got to feel stuff, so you got to have afferents there. And then you have sympathetics everywhere. So when in doubt, sympathetics, postganglionics. Okay, does that make sense? And we talked about the preganglionic sympathetics, and so I just reiterated here kind of what happens with the preganglionic story and the options that you have. Okay, is that still unclear to anybody? And so here is a really good image that I found of pre and postganglionic kind of courses here. So take a look at that. We talked about the collateral ganglia. We talked about the sympathetic trunk. Yada yada yada. Here, ventral root, ventral nerves, visceral nerves, things like that. Okay. And I try to get images that weren't netters because you all have access to that. So I try to find something that was a little bit. If netters wasn't working for you, hopefully maybe one of these images will. And again, this is kind of just the same thing. Here's a prevertebral ganglion. So if I'm going to a prevertebral ganglia, how did I get there? What nerve did I have to get through?
Splanking?
Who said splanking? Yeah, splanking. If I'm going to prevertebral, then how did I get there? Huh? What? Okay. All right. And then again, we've already discussed the postganglionic ganglionic sympathetics and the options that they have if I was postganglionic sympathetic fiber and where I'm going to be found. So again, if I'm postganglionic and I'm coming out of a brain, that means I synapse with my preganglionic in the sympathetic trunk. And so there should be no confusion as to the fibers that are coming out of the brain. Okay, cell bodies, and then we talked about the distinction of visceral nerves above T5, and then we talked about the collaterals. This is a splendic story, and then we talked about neuroendocrine being neurotransmitter derivatives and kind of how they function as direct synapses for preganglionic fibers. Okay, so this is just all reiteration of what we've already discussed. And this is just showing you the whole shebang. Sympathetic fibers. Don't get caught up in this image. You'll want to drive yourself crazy. Okay, but we talked about the big points, and hopefully whatever questions that you guys have somewhat clear themselves up. Okay. Are there any questions about the sympathetics? Oh, yeah. We have one more thing. Sympathetics of the head. So, and this is what you were asking about earlier. So, again, my intermedial lateral cell column goes from where to where? Yes, and it has sympathetics going everywhere, so I still need to get to the head somehow. Okay, so the preganglionic sympathetics are going to go to the highest point that they can before it's time for them to be spent. And so usually T1, T2 levels are what's going to be carrying your preganglionic sympathetics to the head. Okay, and what they do at this point is just you have all these great arteries that are coming along, and so the nerve fibers, once they exit out, are just following along and then concentrate up here in the superior cervical ganglion where they finally make their synapse. And so superior cervical ganglion is C1, 2, 3, and 4, and I remember that because superior has 4 syllables, and so that's just how I remember it. Superior cervical ganglion, and then synapse is there, and then from there, then you're carrying postganglionic fibers to the head and the regions that you need it. Okay. So just remember that for sympathetic innervation of the head, because you run out at T1, you have to have this synapse occurring in the superior cervical ganglion to carry out those postganglionic fibers. Okay? Does that make sense? Anybody have questions about that? Okay. All right. So what's that? I'm sorry. Yes, ma'am.
The superior cervical ganglion are located in C1 through 4.
Yeah, sympathetic or superior has 4 syllables, and then C1, 2, 3, and 4. That's how I kind of remember superior cervical ganglion.
Yeah, the intravenous lateral cell column is C1 to L2, but the automatic for the sympathetic trunk, where does that spin? You said transport,
The sympathetic fibers. Yeah, so they just keep carrying on past. So your preganglionic fiber, your cell bodies in around T1 to T2 if you're going to the head. And then you just keep carrying on, up, until, you diffuse out into the neck viscera and then along the blood vessels. And then all these fibers more or less coalesce at C1 to 4 of the superior cervical ganglion, and then that's where they make their synapse and carry on. Does that make sense? Alright, so now embryology. I know that this was a big point for you guys that y'all wanted to go over, so yeah, challenge accepted. It won't be a big deal. So is everybody clear kind of on, because I know y'all aren't tested on the formation of the bilaminar disc, or the trilaminar disc, I don't think, either. That thing that Dr. Vogel gave y'all, but that really does set you up nicely to understand kind of what happens in all of the embryology that you're going on. Is everybody kind of clear what's going on during that time period? No? Okay. We can discuss that. I hadn't made slides specific for that because y'all aren't being tested, but if you need clarification on how gastrulation is occurring in the formation of bilaminar disc, then we can talk about that. Does anybody know kind of what is the landmark feature that kind of distinguishes the start of gastrulation? What appears? The primitive streak, right? Okay. So your 2 cell layers at this point, your epiblast, your hypoblast, right? So if your 2 layers, you're called bilaminar. Well, the embryo is still round, so we call it a bilaminar disc. Well, the epiblast, and I think it's around 3 weeks. Will they verify that? I think it's around 3 weeks. Beginning of the 3rd week, you start the gastrulation. And so what the epiblasts do is they kind of concentrate at the caudal end. Actually, there's kind of, you can see a little bit. At their caudal end, they start concentrating. And so they're just kind of like, epiblasts are moving together and they're kind of all making a streak because they're kind of concentrated, they're laying on top of each other, and that's the primitive streak. And then most caudal is going to be the primitive, what? Does anybody remember that structure?
No.
What's associated with the primitive streak? Primitive node. So it's just an extra concentration of these cells, and then from the primitive node, the primitive streak points out cranially. Okay, and so the primitive streak, once that appears, is your first point in which you can differentiate cranial caudal, right, left, rostral caudal. You can start making all those distinctions with the embryo. And at that point, you're going to start having the primitive groove and then the primitive pit. Do y'all kind of remember that? So what all of this is doing is you have two layers, but the cells kind of have to like dig out another layer so you can make the third. And so this is what the whole thing with the primitive streak and the node then start invaginating with epiblasts, because you still just have epiblasts and echoblasts. And they start more or less invaginating and digging out a cavity for that that middle layer to come in and populate with mesenchymal mesoderm, basically. And so you have the primitive groove and then the primitive pit. So the primitive groove is associated with the primitive streak. Okay, so the streak is just kind of that line that's shooting out from caudal to cranial, and then that invaginates to make the groove. Okay, so you started with the streak, you invaginate that, now you made it into a groove. Okay, then you started with the pit, or you started with the primitive node, which was a concentration of epiblastic cells, and then you got to invaginate that, and so you turned it into a pit. Okay. And so what is this doing? This is just shelling out cells and allowing them to come in and populate and make a third layer. Okay? Because you have to get to that trilaminar organization before you start actually making anything as far as organs. So do y'all kind of recall that?